Good evening, good afternoon, and good morning to anyone tuning in globally. I'm Victor Zhao, the president of the National Academy of Medicine, and welcome to our webinar, Violent Conflict, the Challenge of Protecting Public Health and Healthcare. This webinar is brought to you by APHA and NAM and the National Academies Committee on Human Rights. This webinar continues to build on long-standing relationship between our organizations to bring rapid and trustworthy scientific analysis around critical issues to healthcare, as well as public health practitioners, scientists, business leaders, policymakers, and the media. If you have any questions on topics you'd like us to address today or future webinars, please enter them in the Q&A box or email us at apha@hpapha.org. Now, if you experience technical difficulties during the webinar, please enter your question in the Q&A. Pay attention to the chat for announcement about how to troubleshoot. This webinar will be recorded, and recording and transcript will be available on events pages for both organizations, apha.org, as well as nationalacademies.org. So thank you very much for being here. My co-host, George Benjamin, will be joining us very shortly, but it's my great pleasure to put some introductory remarks to frame the issue for today. So, the Ukraine crisis, the war, the invasion, to me is an egregious act of violence against humanity. It's an international security crisis, it's a humanitarian crisis, and it is a health crisis. I've been watching with increasing sadness and alarm as healthcare facilities come under fire during Russia's invasion, with devastating impacts on patients, civilians, and frontline workers. Earlier this week, the WHO confirmed at least 64 such attacks, at least as of March 24th, including shelling of a children and maternity hospital. It's just terrible. Many facilities are facing catastrophic supply shortages, even as they are overwhelmed with the influx of wounded civilians. But we also should recognize the war in Ukraine will have negative effects on health that stretch beyond its borders. The disruption of Ukrainian health system will harm the control of infectious disease such as tuberculosis and COVID-19, and the essential services for chronic diseases and chronic illness. And Ukrainian health workers who flee the country may never return. And that's been the case in previous conflict experiences. And Poland and other nearby nations are struggling to provide healthcare and social service to a historic wave of refugees. Millions of these refugees, mostly women and children, will require special care, including mental health, a critical need that will endure the region long after violence subsides. I think the situation is dire. So at least for us, NAM, and I know AHA is very active in reaching out to support those who are dealing with this crisis. For us, we not only made major statements to support them and stand by them, but we're working to offer concrete support and assistance, such as supporting the National Academies effort, led by NAS, to set up a fund to support Ukrainian scientists who have fled to Poland and displaced in local regions. We are working on ways to relocate, efforts to relocate displaced health professional students, medical students and nursing students, and finding ways to support healthcare workers on the ground by partnering with NGOs such as Doctors Without Borders, Partners in Health, and others. So we do know that this crisis is not going to be over anytime soon, at least I think not. And we all stand by to ready to help. And this is why we believe this meeting webinar is so important, because it's really important to bring rapid and evidence-based analysis around the challenges confronting healthcare workers, practitioners, and scientists in times of such crisis. Better understand how they're responding to the challenges, and how care is being delivered, how do you provide humanitarian support, and importantly, how to protect them. And so we think that this can help all of us, you on the webinar, to understand how the Ukrainian healthcare services are being affected, disrupted, and how we can all help. So this is why we've partnered with APHA. By the way, you all know it stands for American Public Health Association, and the Committee of Human Rights of National Academies to organize this webinar. And we have some of the really important experts who in fact participated in earlier meeting forum in January on this particular issue organized by Committee of Human Rights. So without further ado, I would say that I'd like to turn the meeting over. If George is not back yet, George is Benjamin, I certainly would ask Carlos De Real, who's the session moderator, to take over. Is George at this meeting yet? Has he connected?
Yeah, I'm here, Victor. Thank you very
George,
much.
Over to you.
Yeah. Hello, everyone. I just wanted to come on and say welcome. I think this is an extraordinarily important issue. You know, war is terrible, and it impacts health in just so many ways. And so we've tried to get together a series of experts to really give the world a sense of this, our community. So with that, I will turn it over to our moderator, Dr. Carlos Del Rio. Thank you, Victor.
Thank you very much. Carlos is at Emory University, and he has many roles: Executive Associate Dean of School of Medicine, Integrated Health System, Distinguished Professor of Medicine, Professor of Global Health Epidemiology, School of Public Health, Co-Director of the Center for AIDS Research, and co-PI of the Emory CDC HIV clinical trials, and so on. But he also serves as the International Secretary of NAM. And if you watch him on television, you see Carlos more frequently than I get to see him. Thank you, Carlos, for moderating this.
Thank you, Victor. And I want to say that, reinforce that, the tragic effects of war on health and well-being are tremendous and are well known, and they have direct and indirect effects on nations and communities or individuals. More deaths and disability are attributable to wars and conflict situations than to many other major diseases combined. War is a man-made public health problem, as we have seen throughout history, and it continues today, not only with Ukraine, but Ethiopia, Afghanistan, and many other places. And the public health impacts are many. There are deaths, there's injury, there's disability, there's mental health issues because people are exposed to many types of trauma, violence, rape, torture, bombings, death. War induces forced migration with refugees and displaced populations. There's breakdown and destruction of health systems, so public health infrastructure or vital services. There's increased disease transmission. There's an enormous impact on human rights with discrimination, racism, and there's also environmental destruction. In today's webinar, we will hear from experts, each presenting their own perspective on this topic and highlighting strategies for a way forward. Please remember to use the Q&A feature to ask your questions as they arise. With that, I'd like to introduce our panelists. Dr. Barry Levy is a physician and epidemiologist. He's an adjunct professor of public health at Tufts University School of Medicine. He has written and spoken extensively on the health impacts of war. His new book on the subject, From Horror to Hope, will be published by Oxford University Press in April. His writings on the war in Ukraine have been in the New York Times, on CNN, and the Financial Times. He has edited 20 books and has written more than 250 articles and book chapters, mainly on the public health impacts of war and terrorism, environmental and occupational hazards, and social justice. Dr. Levy is the past president of APHA and a recipient of its Selwick Memorial Medal. His presentation today is entitled, The Impact of War on Health, Human Rights, and the Environment. Next is Dr. Jennifer Leaning. Dr. Leaning is Senior Research Fellow at the Harvard François Bagnon Center for Health and Human Rights at Harvard University, and a retired professor on the practice of Harvard School of Public Health. An associate professor of medicine at Harvard Medical School, he's a faculty member of the Department of Emergency Medicine at the Brigham and Women's Hospital. She served as the director of the Harvard François Bagnon Center from January of 2010 until September of 2018. Prior to her appointment, Dr. Leaning served for 5 years as co-founder and co-director of the Harvard Humanitarian Initiative. Her research interests focus on issues of public health and international law in response to war and disaster, early warning for mass atrocities, and problems of human security in the context of forced migration and conflict. She has field experience in assessments of issues of public health, human rights, and international humanitarian law in a range of crisis situations, including Afghanistan, Albania, Angola, Kosovo, the Middle East, Pakistan, the former Soviet Union, Somalia, the Chad-Darfur border, and the African Great Lakes area. She has published widely on these topics and submitted reports and policy briefings to US and UN agencies, the International Criminal Court, and major NGOs. Dr. Levy will address the impact of war on civilian populations, noting variation and consequences depending on the nature of war. Dr. Rohini Haar is an emergency physician and adjunct professor of epidemiology in the School of Public Health and the University of California at Berkeley, and medical advisor for Physicians for Human Rights. Dr. Haar research and advocacy focus on the protection of human rights in times of complex humanitarian crisis and conflicts. She uses epidemiological methods to show the impact of war on human rights violations on health. Her recent work has focused on the abuse of crowd control weapons in protests, the development of the Istanbul Protocol, the manual for investigating torture, and the impact of attacks on health in Syria, Myanmar, Sudan, Colombia, and elsewhere. Dr. Haar will speak on protecting health workers and health services in conflict zones. Finally, Dr. Chris Beyrer is the inaugural Desmond Tutu Professor of Public Health and Human Rights at the Johns Hopkins Bloomberg School of Public Health. He's professor of epidemiology, international health, health behavior and society, nursing and medicine at Johns Hopkins. He serves as director of the Johns Hopkins training program in HIV epidemiology and prevention science, and as a funding director of the Center for Public Health and Human Rights. He's also associate director for the Johns Hopkins Center for AIDS Research and the University Center for Global Health. Dr. Beyrer has extensive experience in conducting international collaborative research in North and South America, Sub-Saharan Africa, South and Southeast Asia, and Eastern Europe and Central Asia. He has spent much of his career focusing on intersections of health and human rights. He was president of the International AIDS Society from 2014 to 2016 and was elected to the National Academy of Medicine in 2014. He currently serves as senior scientific liaison to the COVID-19 Vaccine Prevention Network of the U.S. National Institutes of Health. Dr. Beyrer will discuss the impacts of war on health, disease transmission, and the human rights abuses, focusing on Russia as a case example. With that, I will turn it over to our first speaker, Dr. Levy. Dr. Levy will set the background for our discussion today and speak on the impact of war and health and human rights on the environment. Over to you, Dr. Levy.
Thank you, Dr. Del Rio. Public health aims to ensure the conditions in which people can be healthy. In contrast, war is the antithesis of public health. War causes many adverse effects. It causes injury, disease, and premature death, mental and behavioral disorders, violations of human rights, forced displacement, damage to civilian infrastructure, contamination of the environment, diversion of resources, and often more war. 3 important points about current and recent wars. First, with the number of armed conflicts at an all-time peak, about 1/4 of people worldwide live in regions directly affected by armed conflict. Second, most wars are civil wars, interstate wars, in low and middle income countries. And third, in most wars, the vast majority of deaths are among civilians. Really opposite of a trend 100 years ago when the vast majority of deaths in wars were among military personnel. Civilians die from both direct and indirect deaths. Many civilians die from indiscriminate attacks with weapons ranging from bombs to small arms and light weapons. And increasingly, civilians are targeted, attacked on purpose as part of a deliberate strategy of war. Men are taken from their homes in the middle of night, often never to return again. Women are raped and often killed, and even children are sometimes targeted. However, most civilian deaths during war are indirect deaths, many of which result from damage to civilian infrastructure. When farms and the food supply system are damaged, people become malnourished and more susceptible to many infectious diseases. When water treatment plants are destroyed, people develop cholera and other diarrheal diseases. When healthcare and public health facilities are attacked and healthcare workers are killed or injured or forced to flee, people are unable to receive clinical care or public health services. And when electric power grids and power plants are destroyed, communication networks are bombed, and transportation systems are damaged, more deaths occur. Population displacement is another major cause of indirect deaths during war. Displaced people may be able to cross international borders and become refugees in other countries where their immediate health needs are addressed. In contrast, people who are internally displaced are generally worse off because they have inadequate food, water, shelter, and medical care, and therefore are at increased risk of illness and death. And if war continues, people may be displaced for long periods of time. Both in the Ukraine war and more generally with regard to other wars, about 2/3 of people who are displaced internally within their own countries. An important question to ask is how many indirect and direct deaths occur due to war? To answer that question, I'd like to focus on two sources of data. The first source of data is on indirect deaths, and it comes from Mohammed Jawad and his colleagues at the Imperial College in London. They estimated the number of indirect deaths among civilians in more than 1,100 armed conflicts over an almost 3-decade-long period. They estimated over 29 million indirect war-related deaths occurred during this period, an average of about 1 million per year. The majority resulted from communicable, maternal and neonatal diseases and malnutrition. The remainder were due to non-communicable diseases and injuries. The second source of data is on indirect deaths, and it comes from the Uppsala Conflict Data Program in Sweden, which records direct deaths of civilians as well as combatants. For the same period of time as the analysis I just presented on indirect deaths, it found an average of about 50,000 direct deaths a year in state-based armed conflicts. Comparing these two sets of data, the recorded 50,000 direct deaths a year and the estimated 1 million indirect deaths, we see that there are about 20 times more indirect deaths than the direct deaths based on these data. Now, even if the estimate of indirect deaths is too high or the number of direct deaths recorded too low, indirect deaths far outnumber direct deaths during most wars. In the war in Ukraine, missiles, bombs, and mortar shells have killed many people in plain sight, but not in plain sight. It is likely that a much larger number of people have died or are now barely surviving from lack of food, water, shelter, and medical care. Their basic needs must be addressed immediately. Civilians suffer from the following health impacts as a result of war. They occur more frequently and are more severe during war because of reduced health care and reduced public health services. First, malnutrition, with infants and young children being at greatest risk. Communicable diseases, including diarrheal diseases such as cholera, acute respiratory infections, including COVID-19, measles, and tuberculosis. A third category are mental and behavioral disorders, including PTSD, depression, substance abuse disorders, and suicide. A fourth category has to do with adverse effects on reproductive health. Here we're talking about an increased number, an increased rate of maternal deaths, low birth weight infants, infant deaths, as well as decreased access to reproductive health services during war. And fifth, non-communicable diseases, with war causing both new cases and exacerbation of pre-existing cases of cardiac, respiratory, neurological diseases, as well as some types of cancer. Everyone is at risk, but some populations are at greater risk. Women, children, and older people, displaced people, people with chronic diseases, people with disabilities, ethnic and religious minorities, including indigenous peoples. Among military personnel, war causes death, disease, and disability mainly from injuries and mental and behavioral disorders, but also from communicable and non-communicable diseases. And it's important to recognize that before joining the military, many soldiers were non-combatant civilians who were then coerced or strongly enticed to become combatants. During war, human rights are frequently violated, such as by attacks on civilians and civilian infrastructure, including healthcare and public health services, restriction of food and water, forced displacement, and denial of humanitarian assistance. And other speakers today will further address some of these issues. Human rights, as well as international humanitarian law, are violated by the possession, testing, and use of indiscriminate weapons. And here we're talking about a variety of weapons, including but not limited to cluster munitions, landmines, chemical, biological, radiological, and nuclear weapons. And we mustn't forget that our survival as a species is threatened by the presence of 13,000 nuclear weapons, 90% of which are possessed by the United States and Russia. War and the preparation for war adversely affect air, water, and land in many ways. Use of fossil fuels release greenhouse gases that cause global warming. Burn pit emissions and other chemicals pollute the air. And not listed here are fires, such as the many fires that are being ignited by missiles and rockets in Ukraine now that are causing vast destruction. So not only vast destruction, but also contamination of the air. With regard to water, at many military bases in the United States, for example, groundwater is contaminated with organic solvents and other toxic materials. And in the past, there was vast ocean dumping of chemical weapons at sea. Land use is adversely affected by landmines and unexploded ordnance, by defoliants and other toxic chemicals, and by abandoned military equipment. And the production and in the past atmospheric testing of nuclear weapons has contaminated air, water, and land with radiation and radioactive chemicals. Some indirect effects of war, as demonstrated by the war in Ukraine, include massive population displacement that places women and children at risk of assaults, both physical and sexual assaults, and trafficking. Reduced crop yields, with perhaps 30% reduction in crop yields of wheat and corn exports, at least worldwide, as a result of the fact that the corn and wheat crops may not be planted in Ukraine this year. But certainly the war is disrupting food exports, will lead to food shortages, malnutrition, and food riots and possibly other forms of violence in other countries. Increased military budgets, which means less money for health, education, and the social safety net. Germany almost overnight doubled its military budget, which means that there'll be less money in Germany and for health, education, the social safety net, and this will be replicated in many other countries. And reduced international cooperation causing adverse effects on public health, including surveillance for emerging pathogens as well as scientific research. There are many specific ways of reducing the health impacts of war: by protecting civilians and civilian infrastructure, by providing medical care and public health services, by providing humanitarian assistance, by protecting human rights and ensuring adherence to international humanitarian law. But the only way to eliminate the health impacts of war is to prevent war. This triangle summarizes the major ways of preventing war. First, by resolving disputes nonviolently, such as by diplomacy, arms control, and measures to prevent the spread of violence and to diffuse conflicts before they turn violent. Second, by addressing the root causes of war, including militarism, socioeconomic inequities, ethnic animosities, poor governance, and environmental stress. And third, by strengthening the infrastructure for peace, such as by rehabilitating nations and reintegrating people after war, setting up truth and reconciliation commissions, deploying international peacekeepers, strengthening civil society, promoting the rule of law, and ensuring citizen participation in the governmental decisions that affect their lives. Now, I've spent a lot of time describing the horrors of war, but I want to end on reasons for hope. And these reasons for hope include resolution of many disputes without violence, increased protection of human rights globally, improved and more systematic ways to deliver humanitarian assistance, effectiveness of many international treaties, and more people and organizations throughout the world working to prevent war and to promote peace. Thank you.
Thank you, Dr. Levy. Now over to you, Dr. Leaning.
First slide, please. Tom, next slide. Thank you. So I will be talking about the prevailing patterns in current armed conflict in regard to its impact on civilian populations. Next slide. Here we go through a number of categories: the patterns of armed conflict, the norms of war, forced migration in war, the impact of war on civilians and demographics and infrastructure. Speak briefly about the Soviet-Russian wars of the 1990s to 2022. Next slide. Current wars are primarily non-international armed conflict, NIAC, in the words of the International Committee of the Red Cross. They take place within the borders of nation states. They are the most deadly to civilians. They last for years. They result in mass forced migration, precipitous forced migration. They destroy societies, and they are unleashed by animosities within a country that prove to be very destabilizing to the long-term integration and integrity of the post-war setting. A devastating subset of non-international armed conflict are called internationalized internal conflict, when a conflict arises between two parties within a country or between a rebellion in a country and the sitting government, and then the intervention of another sovereign state into that internal war. That's called an internationalized internal conflict. And we saw it most vividly in the context of the war in Syria. Next slide. This is a graphic that explains this. These are trends in war since the end of World War II. And the massive yellow section depicts non-international armed conflict. It is vividly obvious that these are the predominant wars of our times, of the last 75 years. The jagged red surface are those internationalist internal conflicts where another sovereign state intervenes into this dispute within the civil conflict. And down at the bottom, the blue line depicts what people often think about as armed conflict, which is an international armed conflict between nation states. These are increasingly very aware, and we are concerned, obviously, in the context of Ukraine, about the involvement of other nation states, in addition to the involvement of Russia. The green, incidentally, are the conflicts that arose at the end of World War II, and these are predominantly anti-colonial wars, which are in some ways a subset of civil wars, but they are opposed to a power outside the borders of that country. So this is a depiction of prevalence of war, not incidents. And so that means this is not every year a war reaches 50 in any single year, but these wars are very, very difficult to bring to an end, particularly the internal wars, the non-international armed conflicts. And so we are seeing this burden of terrible destruction persisting throughout our lives. Next slide, please. A depiction of the ways in which non-international armed conflict can destroy wide populations, and also the terrible aspect of an internationalized internal conflict can accelerate this destruction of people, comes from epidemiologic studies done very well in the First and Second Congo Wars, which were called the African World Wars in the 1990s and early 2000s. And it shows visually that for every violent death, that is a military death or a combatant death in the Congo and adjacent countries, there were 62 non-violent deaths from this conflict. So we can see that children under 5 represent a significant proportion, and children ages 5 to 15 also. but all are involved. And the reasons people die, as Barry mentioned, are malnutrition, respiratory disease, a range of infections, particularly measles and malaria. That's the fever under there, and then other causes. Next slide, please. The norms of armed conflict, international humanitarian law, seek to contain atrocities, that is really vicious actions during war, and seek to maintain possibilities for resolution so that there are norms of decencies that are upheld in the face of atrocities. These are enunciated in a range of conventions and treaties that have been elaborated since the mid 1800s, and I'm sorry, since the mid 1900s. And they evolved almost simultaneously with interactions during the US Civil War and in Switzerland, coming from the Henri Dunant witnessing of the wars of Italian reunification in the 1850s and early 60s. So these notions of protecting civilians from war, reducing atrocities, bringing war to a close, were enshrined in two major bodies of international humanitarian law: Hague Law, which deals with weapons and their use. Here are all the disarmament conventions are products of Hague Law. You can see that the Landmines Convention, a landmark piece of Hague Law, belongs in this pantheon. And then Geneva Law deals with the identification and protection of persons, non-combatant and combatant. And the reason to identify these two categories of people is to protect the non-combatants from the active violence of lawful violence, hopefully, of the combatants, and to identify them so it is very clear to tell one from the other. So that is part of the ICRC's insistence that all soldiers, military personnel of nation states are clearly identifiable when they're in the field. Next, please. Forced migration in war is always present, but the ways in which it occurs vary considerably. And the worst forced migration, often massive forced migration, is precipitated by unrestrained attacks against civilians. And in these categories, you can get very, very vicious behavior. This is where ethnic cleansing takes place. And in particular instances, you also see genocide. So there's no wonder that people are fleeing. But they can only flee if there are options for them to flee. And so civilian flight is eased by rapid modes of exit. That is, if they're good roads, if there are protection along the way, if they are near friendly borders that they can cross. Here you see refugees as they are moving in Ukraine. They're being accommodated out, crossing into the friendly borders of Eastern Europe. And the large numbers suggest how violent it is in the places that they call home. Flight is inhibited by very harsh rain and the absence of friendly borders. And this is where one sees the production of internally displaced peoples. People move to a part of the country that is less likely to be attacked or distant from the kinetic activities, but it is very difficult for them to traverse high mountains, fierce rivers, to get to borders of a neighboring state. And then in these situations, the neighboring states are not friendly. So IDPs are trapped within the boundaries of their own nation state and often subjected to repeated attacks by the assailants. Next slide, please. This is sort of a rough slide compiled by the US Committee for Refugees that depicts the number of refugees from 1945 at the end of the war in Europe through 2015. And as you can see, there were 50 million refugees. They blurred the term refugee and internally displaced persons back then. And this slide accommodates the combination, even though UNHCR, the UN High Commissioner for Refugees, makes very important legal distinctions between refugees and IDPs. And they even make stronger distinctions between those who are considered legitimate refugees and those whose status has not been determined. So it's complicated, but these are the total numbers in flight from war. And you can see at 2015, we're at about 60. I should note that in 1945, these 50 million were only refugees and IDPs counted in Europe. The millions that were displaced by World War II elsewhere on other continents were not counted in 1945 in this number. Now it's more ecumenical, and these 60 million in 2015 are from all over the world. Next slide, please. This is a terrible slide, and I apologize, but if you look, this is up to date, and if you look at the upper left-hand corner, the green graph is the number of IDPs. The blue graph at the bottom is the number of refugees, and the total, not counting the little bits and pieces as part of this, the total is now at 83.4 million people as at the end of 2021. So the number is now over 80 million people are refugees and IDPs throughout the world. Next slide, please. Now, if we talk about the impact of war on civilian populations beyond the forced migration parameters, the traditional modes of assessment usually rest on mortality and morbidity measured in contemporary time, that is in the first 2 or 3 years after the war, and to some extent during the war, if apprehension is possible. And there is a cursory assessment of the longer term issues in general. And this is a very important problem because one does not know how bad war is unless one looks at the longer term issues as well. Now, the longer term impacts will vary depending upon war typologies that I will depict in subsequent slides. But depending on how long the conflict lasts, how brutal and intense it is, how pervasive it is throughout a society, one will have different outcomes for people and for the land. And it also, whether you're talking about the more contemporary assessment of mortality and morbidity or the longer term impacts, the assessment will depend upon who remains to assess these elements. And that also turns out to be a very pivotal factor we overlook. Next slide, please. The delineation of mortality is usually in military terms, killed outright or died of wounds. Now, there are parameters of timing for died of wounds when, if it's within the first 6 hours or so, it's considered that they are killed outright. But there are many people, military now, that are wounded who will persist for a long time. And that then depends upon the nature of the wounds and the extent to which there is short transport time and medical, nursing, and hospital assets available to the wounded soldier. These parameters also apply to civilians who are wounded in war, but as we know well, the assets that are available to them are often destroyed in the war, and the transport to these assets is very difficult to find. So killed outright is one measure. Died of wounds is a much muddier measure and extends for a longer term of apprehension. The medical, nursing, and hospital assets are consumptive of resources. So the militaries of the developed world have much better medical support for advanced forward care than do the militaries or the armed groups elsewhere in the world. Then there is another category of people who die of illnesses and conditions because of depleted peacetime resources, or as civilians, because they get entrained in the military kinetic aspects of the war. They are bombed or they are killed in close combat. And how one thinks about mortality has implications for longer term population dynamics. Next slide, please. Because we also have morbidity, which is related to war wounds, and people may die 10 months out, 10 years out, if they have had an injury from a high velocity bullet wound that swirls around the abdomen and does enormous internal damage and then slams into the spine. They are left paralyzed from the chest waist down. and they have lingering war wounds and drains that often are persistent sources of infection and disability and debilitation of their attitudes towards life, leads to depression. And these are wounds that are associated with significant disability and disfigurement, burns, head injuries, amputations, particularly in countries where there are not good roads and no elevators, no hard surfaces. Getting around in crutches is very difficult. And those have had extensive surgeries with all the complications that are attendant upon that. So the impact of war is related to who survives with what disabilities over what time frame. So one speaks, I'm never saying blithely, but when one speaks quickly about morbidity and mortality in war, one should recognize that there is a long tail of ugliness and immobility and depression and grief that attends these war injuries. Next slide, please. I mentioned topologies, and here I'm just going to go through them quickly so your visual memory will go with your auditory memory. Pervasive, I'm talking about a war that has massive geographic extent, that is within the borders of this nation state involved. High level kinetic impact in terms of bombs, and leading to effects on gender and social roles because they so disrupt the population, and the effects last for a very long time. Afghanistan has been victim to pervasive war over space and time. Intense wars are those that are delivered in either one-sided or very disruptive match side of warring parties, which deliver overwhelming violence to the civilian population and cause widespread destruction of environment and infrastructure. Wars have intense periods, they have intense geographies. This does not usually extend an intense war throughout the entire nation state, but this intensity where it occurs is extraordinarily damaging. And then brutal wars, and all wars have aspects of brutality, but if one studies war, you realize that there are some wars that are waged with extraordinary brutality, armed forces against armed forces, but civilians against civilians, and non-organized combatants and not trained, but with the capacity to assault people and kill them in brutal ways. A brutal war, which can be short or long. Again, it doesn't entail a spread across an entire country, will really inflict tremendous pain and suffering. The atrocities will leave people with memories of victims and perpetrators, and a need to retaliate over time. Long-standing psychological consequences, mark social divisions, and these brutal wars really imprint on historical memory. They persist in animosities between and among people, between and among nation states. And then the duration of this war, including all the negative aspects we have covered, but also creating great impediments to population return, create marked generational alienation. That is, children grow up in war, children grow up in refugee status, children grow up in IDP status, and they do not know what their country is. And they don't know who else is outside their country or who is in their country. They're trapped outside or inside. And if and when the war ends, re-knitting that society and creating another country winds up being terribly difficult. Next slide, please. Next slide, please. I would like to end with some photos from the wars that we are talking about now in terms of Soviet or Russian involvement. Afghanistan, this is the Selang Pass, which is one of the most important routes throughout the country on the northeastern side. And you see Russian assault on that hillside town. Next slide. This is Grozny, Chechnya, in the beginning of the Second Chechen War, where the Russians were infuriated at Grozny for continuing to be so disruptive and a brutal war. And so they bombed for 3 months the city of Grozny. Next, please. This is East Aleppo, 2015, 2016, Soviet bombing of this stronghold of the rebels. Next slide, please. This is satellite of Mariupol, Ukraine, about March 25th. You cannot get the kind of visual impact because the war was too active, but the satellite photo gives you some incidents of indication of what's going on. Next slide, please. This is another Syrian city that was bombed by the Russians. And the person who took this photo knows the history of war photography. Next slide, please. This is the iconic version of the Holmes photo. Next slide, please. This is Dresden, March 1945, after the firebombing of the city. And I end on this slide, and just to say that this is the sort of situation that many of us fear, think about, and dread when we're talking about war, the demolition of a society, the long journey back. And if one wonders why someone in public health and human rights spends time on these topics, Margaret Atwood in a poem put it very well, that for every year of peace, there had been 400 years of war. Thank you.
Thank you, Dr. Leaney. That's very sobering. Next is going to be Dr. Rohini Haar. Rohini, why don't you go ahead and start it?
Thank you, Dr. Del Rio, and thank you, Dr. Leaning and Dr. Levy. I'll focus for the next 10 minutes or so on the protection of healthcare in conflict settings, particularly on protecting healthcare workers, patients, facilities, and transports from violence and attacks. As a practicing physician, this issue is particularly close to my heart. It has been hard enough to work through COVID and see the fatigue on my colleagues' faces, but to imagine doing that in the setting of a war with everything that you just heard makes me feel so much compassion and commitment to supporting our colleagues. This is a picture of an archaeological site in Raqqa, Syria. A number of years ago, I met a doctor who is now a close friend and colleague. He asked that I share his story and his name with you. Dr. Nasser Al-Mahwish is a general surgeon from Raqqa, but he has not operated since 2014. After the Arab Spring protests that rocked Syria in 2011, he was attacked by police who would target healthcare workers for caring for protesters, part of their medical obligation to treat everybody. In 2013, he was conscripted into military service, but his conscience forbade him from working for that military, so he left his home and his job. By late 2014, airstrikes falling all over northern Syria made working in the hospitals dangerous. And soon after, ISIS took over Raqqa, and not only were there airstrikes, but ISIS soldiers demanded priority treatment and strict adherence to their rules. He had to leave, but some of his family stayed and suffered again when the United States bombed Raqqa to rout out ISIS. Today, he lives in Turkey, where he cannot work as a physician. He wrote this to me one day. Staying anywhere in Syria was a death sentence. It was hard enough to work long hours for continuous days, managing the trauma of my people with minimal supplies. But doing all that with no security was an impossible situation. I left my country, my family, and my beloved profession. I share that story for two reasons. One is to give a human face to what health in conflict looks like and amplify and uplift the voices of the individuals who are experiencing it. The second is to illustrate the complexity of violence against healthcare. Sometimes it can be airstrikes, like what we have seen in Syria and now in Ukraine, or it could be threats or intimidation, or confiscating medications, or occupying a hospital, or blocking access for some groups, or even in trying to influence triage decisions. Anytime that healthcare has outside influences, even in peacetime, it can be bad for health workers, patients, and the entire community. My hope today is to share with you two main points and back them up and explain them a little. The first is that we must see a problem before we can work on solving it. And the second is that violence on health has impacts far beyond the immediate. Seeing the problem can take several forms. It means hearing the voices of health workers and patients who have experienced this violence. A colleague from Syria shared this, but then the airstrikes began. It was clear from the sky that this was a medical facility, but it didn't matter to anyone. We tried to put people in the basement, but bombs can damage everything and people didn't feel safe anywhere. A colleague in Sudan shared this. If I am completely honest, every time I participated in the protests, I was terrified that something would happen to me because I'm a doctor. But I didn't want to be selfish. I wanted to participate because I believed in what's right for my country. And most recently, a nurse in Myanmar shared this with me. We are not heroes. We are just trying to do our job taking care of sick people, but under the low hum of oppression. When they nick our oxygen lines and try to arrest us, we just do that job underground and in secret, but we do not want to be martyrs. Seeing the problem can also look like what my colleagues at Safeguarding Health in Conflict Coalition and Insecurity Insight, colleagues like Len Rubenstein and Christina Ville do, as well as Physicians for Human Rights, ICRC, Air Wars, and many other organizations, researchers, and my colleagues on this panel do so tirelessly. It means counting the incidents and mapping them. This graphic is from a forthcoming report. 43 countries with violence against healthcare and more than 1,000 unique incidents in 2021 alone. It means understanding what each incident does to the community, its impacts. And it means identifying and naming perpetrators and sending that information to the folks that can do something about it. This graphic uses data from Physicians for Human Rights on attacks on health in red, and publicly available information on civilian deaths over the same time frame to study the intensity of war. The civilian deaths are in blue, and you can see that while they trend down, attacks on health are trending up. One explanation is that the health system breakdown means no one is counting the dead or those who left. But infrastructure attacks are visible from the sky, and they are continuing. It just paints a picture of conflict intensity and what it can look like, and that really no one measurement of it tells the whole story. This was from a study last year. We used publicly available information from Air Wars and Insecurity Insight to look at civilian violence in Syria, to identify perpetrators, not of one attack, but of the trends in aggregate. Things that are closer together are well associated. You can see that Russia is associated strongly with civilian violence in Aleppo in 2016, and the Syrian government is associated with targeted attacks on healthcare. But the United States is not off the hook. The US coalition is associated with significant violence against civilians in Raqqa in 2017. That is all just to briefly say that studying and understanding a problem means documenting, reporting, characterizing, and investigating it. But why? So what? Well, when something bad happens, what do we want to do? We want to catch the bad guy, we want to help the victims and the survivors, and we want to make sure it doesn't happen again. In formal terms, that's promoting accountability. Without the evidence and the data, it's hard to hold anyone accountable, whether that's legal accountability, which can take years and hopefully not decades, or if it's in the court of public opinion. It can also mean prioritizing resources to the people who need it the most by figuring out who is most at risk or where violence was most intense. And finally, by shining a light on violence and its perpetrators, we bear witness. And by doing so, hopefully, prevent other atrocities in the first place. The fact that we are having this panel and that so many of you are here today gives me so much hope that we are bearing witness to the violence in Ukraine now, and that attention can spread to other conflicts that are happening everywhere. The second point I want to make is that violence on health has impacts far beyond the immediate. It can limit health services and capacities in both the short and the long term. Rebuilding hospitals and training new workers can take years, if not decades. It can break down the entire health system, and it can result in a chilling effect, in a fear of seeking health service. All of this, in medical terms, ultimately leads to what we as doctors fear the most: increased morbidity and mortality. I'll just give you one example. Between 2001 and 2011, there were 11 reported cases of measles in Syria based on a very well-functioning health system. From 2011 to 2015, the health system was in tatters and there was really no reporting. But my colleague and friend Nasser and his colleagues at the ACU in Turkey are doing surveillance in Syria since 2015. Together, we identified more than 30,000 cases of measles between 2015 and mid-2019. 30,000 cases. The chilling effect of attacks on health is hard to measure, but obvious to everyone. When one hospital is attacked and there's no accountability, patients or potential patients naturally fear going to any other hospital. You can imagine that after the bombing that everyone heard about in the maternity hospital in Ukraine, that other pregnant women might be afraid to deliver in a hospital next door or even miles away. I've painted a harsh picture. So how do we do better? I think we have a fragile window of opportunity now. The attention that Russia's attacks on health in Ukraine has brought is unique. The WHO has responded with over 72 verifications of incidents, which as a member state organization is gutsy. And we have more data than ever to identify, verify, and report these attacks. Satellite technology allows us to see more from far away than ever before in real time. Media monitoring is getting better and better, so we can capture the voices of individuals on the ground and use data science and machine learning to find those incidents in news reports and social media, small and large. And the strengthening decolonization movement begs us to empower local health workers to engage in humanitarian advocacy and report their own stories. My goal, our goal, is to support their work and amplify their voices. So, as you think about Ukraine and violence against healthcare, I hope it draws you deeper into the issue and underscores all the other places where wars are currently happening and where healthcare needs more protection. I urge you to think about those wars, as well as the wars and the impacts on health. I would start with Yemen and maybe Ethiopia. Thank you. And I'd like just to end by saying it takes a team to be in the thorn in the side of injustice. Over to you, Dr. Beyrer.
Thank you, Dr. Haar. This is really fantastic and very sad. Our last speaker is Dr. Chris Beyrer. Chris, take it from here.
Okay, well, thank you very much. And maybe you could just put up, I only have one slide. I'm not going to use slides. Just to say that I have worked in public health, infectious diseases in Russia and in Ukraine. And the last time that I was in Kyiv was actually for a Lancet event with my great friend and colleague, Sergei Dvoryak, who's the head of the Ukrainian Public Health Institute. And the first day of our workshop, I was asked, did I want an English language newspaper or a Ukrainian language newspaper? And I said, English. Unfortunately, don't have any Ukrainian. This was July 29th of 2017. And this is the front page. Russia's war against Ukraine has killed at least 2,727 soldiers. And then there were the photos of all of these people from the last week. This, of course, was the war in the Donbass. So I think one thing we all have to be mindful of is that the Ukrainians have been under aggressive attack from Russia for 8 years. This war has been underway since 2014, although obviously, if we use Jennifer Leaning's definition of the topology of conflict, this now, of course, is on another level, as we all know. So you can turn off the slides now. So I just want to make several additional points, and sort of going last, hopefully I can have a little bit of a sense of organizing this before we begin the discussion, and I'll try and be brief so we have enough time. The first thing I want to say is that I think it's very important when people look at the way this war is being reported, that you see language like indiscriminate attacks on civilians or bombing and shelling of civilian areas. It's very important to understand that that is not a side effect, and the attacks on healthcare are not because of indiscriminate bombing. This is the Putin playbook. As you saw from Jennifer Leaning, this was a prominent part of the terrible destruction of Grozny in the Chechen War, the Second Chechen War. This has been deliberate policy in Syria, more than 500 healthcare facilities attacked. And we know that this is deliberate because eventually the Syrians, in their innovation trying to provide care, actually built underground a hospital and other healthcare facilities. And then the Russian Air Force added these deep dive bombs that can go down into the earth to blow up those underground healthcare facilities. This is policy, and it is a tool of terror. It is an attempt to break the back of the resistance and to terrorize the civilian population into capitulation. And so we have to understand that this is deliberate, and that, of course, makes it a war crime. Rohini, of course, made the point about accountability and how long it will take. I want to talk about impunity in a moment, but I just want to say that this deliberate bombing of healthcare facilities and other civilian facilities, including, for example, a theater that was clearly marked as a place where children were sheltering, is a war crime, and that Vladimir Putin must be held accountable for. The second point I would like to make relates to the public health aspects of both of these countries, Russia and Ukraine. And this is really important because I think it is not understood the extent to which Ukraine had moved away from the old Soviet system and the Russian imposed system of essentially ideological approaches to public health, not using data from clinical trials, not using what we would call evidence-based medicine, and instead having very rigid ideological approaches. And I'll just give you one or two examples of that. The first is something that we're very concerned about. Many will know, others may not know, that Russia has the most severe HIV epidemic in Europe, if you consider Russia Europe. It has a very high burden epidemic, particularly among people who inject drugs. It does not allow any medication-assisted therapy, so no methadone, no buprenorphine, no modern approaches to the management of a substance abuse disorder. And they seek to impose this view, their worldview, without evidence on all the countries they seek to influence. And there's no clearer example of that than the fact that the Russians stopped methadone distribution in Crimea on the first day of their illegal occupation of Crimea. Most other, nation states, when you occupy a piece of somebody's territory, you go after the television station and the parliament and, all the things that we know of about occupations. Stopping methadone on the first day speaks to how ideologically important this is to the Russians. It's, of course, incredibly cruel, and it is not evidence-based. The second issue relates to what we're also all concerned about, which is the COVID epidemic in the region. Ukraine was having a quite serious Omicron epidemic in late 2021 and early 2022. Many will have seen most recently the report from the Global Burden of Disease Group on excess mortality in COVID over the last 2 years. And it turns out that the country that has had the largest excess mortality from COVID of any country is Russia. And a lot of that is because in Russia and in the region, in the countries around it, including many that are now taking Ukrainian refugees like Moldova and Romania, there is very high rates of vaccine hesitancy and very low rates of vaccine coverage. And a coverage with a very mixed picture. Ukraine was using 7 different COVID vaccines, including Sputnik 5 and the Chinese Sinovac vaccines. And the challenge, and one of the reasons why there is so much vaccine hesitancy, is, of course, because Vladimir Putin wanted to have the first approved COVID vaccine before the US or the Chinese or anybody else. And so by diktat, they approved Sputnik 5 for use in Russia and exporting it and donating it to the countries they seek to influence before doing the phase 3 efficacy trial without evidence for efficacy or safety. That is absolutely a violation of scientific norms, of the way modern medicine is practiced. And it has had lasting impacts because people are concerned about that vaccine, unwilling to take it, and it has prolonged and worsened their epidemic. If the Russians prevail in Ukraine, I can assure you that the first thing they will do is reverse the advances Ukraine has made in modern public health. They will stop methadone in the whole country. It will be the end of programs for LGBTQ populations. I worked for 11 years in Russia on gay and bisexual men's health. That ended up being shut down by Vladimir Putin's policies in 2014. It is no question that they will seek to impose this ideological approach on Ukraine. And it's also important to understand that this is part of why they perceive Ukraine to be a threat, because Ukraine has been embracing the West and Europe and moving toward evidence-based approaches and human rights affirming approaches in public health and in medicine. That's part of the problem as far as the Russians are concerned. The third point I want to make, which I think is really important, and others have not really raised it, so I just want to highlight it, is that one aspect of this Russian war on Ukraine and on the Ukrainian people is also that it is an info war. There is an enormous systematic campaign to distort the nature of reality. It is now illegal, as many of you will know, to use the word war to describe what the Russians are doing in Ukraine. They are, of course, launching what they call a campaign of denazification, using Nazi ideology, which echoes with World War II experiences in Russia and what they consider their great patriotic war against the Nazi state. But it is a complete inversion of reality, right? So the Russian spokesman, Peskov, for the Kremlin was just on public television this week. And when he was asked about what the Russians have done in Mariupol, which is including where the maternity hospital was bombed, he said, oh, the Russians, we do not attack healthcare facilities. We do not attack civilian facilities. That's the Nazis in Mariupol who have done this. Of course, the Russians in this case are the Nazis. It's a complete inversion of reality. And we have to pay attention to that because that Russian disinformation campaign, as we know, affected, for example, our 2016 presidential elections. The President Biden has already said that we are at risk for cyber attacks from Russia. This is a part of their asymptomatic warfare, knowing that they don't have military advantage over the United States, that they have deployed against us and likely will again. And it makes, of course, the whole disinformation campaign a globalized aspect of this conflict, right? We are up against disinformation. The final point I want to make is about impunity for these attacks. So one of the really terrible aspects of both the Chechen war and the Russian bombing campaign on behalf of the Assad regime in Syria is that there has been essentially widespread impunity for these attacks on healthcare. In fact, if you look at the record of this, and Jennifer Leaning is a world expert on this, there really have only been really one successful trial and conviction for attacks on healthcare and conflict, and that was in the conflict of the Bosnian War, where you may remember a horrible episode where forces on one of the Serbian sides attacked a hospital and killed all the male patients because that was part of their campaign against men and boys in Bosnia. That actually led to convictions. One of the reasons why there was so much impunity, or has been ongoing impunity for Syria, is because neither Russia nor Syria is signatory to the International Criminal Court. But here's a bit of hopefully better news, which is that Ukraine is signatory to the International Criminal Court, has already asked for an investigation for Russian war crimes in this current war, and that has been accepted. This may be really one of the first times, as Rohini was alluding to, that we actually have an end to impunity for attacks on healthcare in conflict. And that would be so extraordinarily important. The immense suffering of the Ukrainian people is nowhere near commensurate with the idea that there might be some accountability. But one of the reasons why that is so important is because of the long-term consequences of these kind of conflicts, that the truth really needs to come out. As Dr. Levy mentioned, the idea of a Truth and Reconciliation Commission. And it simply cannot be that the Russians can bomb hospitals and other civilian facilities, get away with it with impunity, use disinformation and misinformation to say Nazis did it, we had nothing to do with it, and that is the world that we live in whatever happens post this current acute Ukrainian crisis. We have to have accountability. It's the only way that people can really get lasting justice, and justice is a part of reconciliation. Justice is a part of nation building. Justice is a part of healing, and people desperately want it. When we've been in these conflict zones and in these situations, the idea that the world doesn't care and that no one is held accountable for their suffering is intolerable. And the idea that somewhere down the road there may really be justice and truth will out is hugely important for people. And so I don't know if anybody is able to access this in Ukraine, but certainly if there are others who are working on this, I will just say it really matters that we go after this impunity, and it's essential to what will be, I think, the long-term outcomes of this horrifying conflict. So I will stop there, and thank you very much for your attention.
Thank you, Chris. I will now like to ask all our speakers to turn on their cameras and their microphones, and we're going to be starting with some questions. And I will start first with a question here for Dr. Levy. It's often debated as natural resources are stressed, either by overconsumption or climate extremes, conflicts can arise over access to dwindling resources. How well have this been documented?
Great question, an important issue, not documented well enough. Two comments. One is that dwindling resources, including, by the way, drought in part due to climate change, needs to be better documented. It is something that there's increasing evidence that climate change may, at least in some circumstances, lead to conflict, and some of that may be through a pathway that includes drought and people moving from one area to another. It may have been, in fact, a contributing factor in the Syrian civil war. The other issue that question raises tangentially is the whole issue of resource wars. Many, and Michael Clare and others have written extensively about this, that wars are fought either within countries or between countries for scarce resources ranging from diamonds to rare minerals to oil and gas to farmland. In fact, there's a column in the New York Times today, I think it's by Brett Stevens, who argues, and I don't necessarily subscribe to the argument, but he characterizes part of what's going on in Ukraine as a resource war, and he alleges that Russia's interested in the oil and gas, and by the way, they're probably interested in the farmland. Ukraine is the breadbasket of, one of the breadbaskets of Europe. So it's a very important question. The bottom line answer, it hasn't been studied and investigated well enough.
Thank you for your answer. Question for Dr. Levy. It seems nobody paying attention to the international conventions of war anymore. Is it fair to say that wars are getting more and more violent?
That's also an excellent question. The role of the US has not been excellent in highlighting the importance of the International Criminal Court. We're not a signatory, and we are not a member of the court. And that is in large measure, according to legal experts, because the United States wants to shield its soldiers, its military, from potential vulnerability to a legal charge and being brought before the International Criminal Court. That is a plausible reason, but it is turning out to vitiate much of the court's capacity, because our resources in helping to fund the court and our support in terms of personnel could be markedly increased if the United States became a signatory and a participant. The problems of bringing to justice the people, because this is a court, so you are making a charge, a criminal charge against individuals. The problem of bringing to justice an individual who has committed war crimes or on the gamut of crimes against humanity, genocide, and now wars of aggression. The problem is developing an adequate dossier to withstand a judicial process where there will be a defense. And judges at the ICC are deeply learned, but they come from all over the world. They have different points of view. So it's important to have the best evidence possible if you are charging somebody with crimes against humanity or war crimes. It's somebody who should be a head of state or a person of significance. And that again is a paper trail and an evidentiary trail of various kinds that is really hard to put together. The ICC is not sufficiently funded to go into countries to do a lot of that work. They rely on others. Increasingly, they are going into the countries, but they're careful because the issues of reprisal are there. So they have to do this quietly, obviously. So there are many cumbersome reasons that are rooted in real problems that mean that the courts that we have set up cannot do more than they are doing for the time being until the US changes. But what they are doing for the time being is actually identifying key issues and making it clear that it is not possible for the worst offenders where there has been evidence gathered to escape. So you have some of the worst offenders from the Bosnian War. You have a number of people being charged because of the war in Sudan. There are people who have been charged and brought to book because of the genocide in Rwanda. As I go through this litany, there is an obvious lag in time. There are people from Syria that should be charged. There are people from Russia who should be charged and who should have been charged in previous excursions into other countries. The United States should be charged. But of course, that is the third rail in American politics. So I appreciate that question. And I'm sorry my answer is not more ringing of finality and progress, but it is a persistent, dogged work that the court is doing, and it needs all our support.
Thank you. Dr. Haar, a question comes from the audience. To what extent has remote warfare, like smart and dehumanized warfare, such as the use of drones, made attacks on healthcare workers and civilians more likely?
I think the increased technology and weaponry has definitely worsened things. I think, looking back in history, the existence of air strikes and missiles is what dramatically increased civilian deaths in the first place. And since then, it's worse. For drones, I think it gets even more complicated because the individuals who are firing those drones could be pretty much anywhere, much farther away. And so that link between the soldier and the victim perhaps is much farther. In terms of healthcare, I don't know if I've seen specifically drone attacks on healthcare as a target, but certainly on civilians and civilian infrastructure.
Thank you. Dr. Beyrer, a question from the audience. You keep referencing evidence-based. How do we understand evidence-based in terms of war? Are you referring to the tactics of war, interfering with peacetime health practice? What are you calling evidence-based?
Yeah, so thanks for that. What I was specifically referring to was the distinction between the public health practices in Ukraine before February 24th, and the Russian approach to public health. So, for example, there is abundant evidence that methadone is an effective treatment for opioid dependency, and there is good evidence that it can reduce acquisition risks for other diseases like HIV, hepatitis C, through reducing needle use and needle sharing. The Russians just outright reject that. Their approach is not based on scientific evidence. If you have done, which I have done, and presented some of this evidence at Russian national meetings, the immediate question that comes back is, for example, well, who funded that clinical trial? Wasn't that funded by the United States? In which case it's completely discounted. Without recognizing that, we have a process that we have randomized controlled trials, that we have data safety and monitoring boards, that we have independent review. It's very much part and parcel of the way that they approach public health. So, for example, licensing a COVID vaccine and approving it for use and distribution before you've done an efficacy and safety trial is not evidence-based medicine, right? So that's the distinction that I was making. I will also add that I saw another question in the chat about how disinformation might relate to, for example, vaccine hesitancy in this country. And there is good empirical evidence that that disinformation actually has had a major impact on vaccine hesitancy around COVID. And unfortunately, that has led to a large number of preventable deaths. So it's a danger here, and it is a threat to public health and human well-being wherever it's happening.
Thank you. Dr. Levy, a question from the audience. Kaja Kallas, the Prime Minister of Estonia, said last week that we must prepare for war in order to prevent war. Dr. Levy, considering the prep for war is not listed in the ways you showed to prevent war, how would you respond to the Estonian Prime Minister, who's faced with the real threat of her country by a country that has invaded others and can easily invade hers, and particularly as long as this threat continues?
Yeah, I'm not familiar enough with the situation in Ethiopia to comment on that.
This is Estonia.
Excuse, I apologize, Estonia, to comment on that specifically. But I might just say that to the extent, I'm talking now in general, to the extent that nations arm themselves, and become more militaristic, they will increasingly, and there's a lot of history to support this, they will increasingly see so the solution to problems as violence. And I'm not making a comment on the situation in Estonia, but I think even in our own country, and maybe our own country is the epitome of that to the extent that we arm ourselves and spend so much money on military weapons and think from a militaristic point of view, we think that solutions are militaristic. That's it.
Thank you. Dr. Leaning, with internally displaced persons, what is the best way to provide psychosocial support and sustenance of coping skills while the war is still ongoing? Dr. Indira Selvraj, chair of the Global Crisis Intervention Commission, World Federation of Music Therapy, asked this question.
It depends on whether one has access to the internally displaced peoples. But increasingly, there are ways in which the humanitarian organizations, the international ones and regional ones, are managing to gain access in terms of delivering the essentials of healthcare and medicines, shelter, water. And as part of that package of care, there is an increasingly sophisticated mental health approach. And it could be more, all of these emergency assistance and long-term issues could be more carefully limed out, and the care delivered more precise to the needs of the population. But I would say that with time, as the humanitarians get to know the IDPs better, because these IDPs are there for a long time, they become actually very sophisticated authorities with their country staff on what is going on. And so the mental health care that is being delivered is over time more precise, more aimed at what the particular issues are, a nuance between sort of children, very, very aware of gender issues, and do help in addressing some of the issues of grief and persistent incredulity at the loss that people have suffered. But I would say that there is not much psychiatric treatment of any sophistication to deal with the people who are mentally ill and made worse, of course, by the war and displacement. That remains a very big problem. And the other issue is that people can be eased and soothed and understood and to some extent reconciled to what is going on, but fundamentally, they need to get home. And so long-term, an internally displaced person is a person without a country and a person without a future. And all forms of aid will keep people alive and keep them to some extent in one piece, but they are not fundamentally at peace or fundamentally at home with themselves.
Well, thank you very much. Well, our time is almost up. So I want to first of all thank all our speakers for what has been just a very rich and insightful and quite frankly, very concerning and depressing webinar. A lot needs to be done. And I think, you know, a peace should be a priority for all of us. And it's unfortunate that this kind of things continue to happen, not only Ukraine, but globally. We cannot forget all the wars that are occurring in countries. Somebody typed about Sudan, and we can go on and on and on about the areas of the world that are in conflict induced by humans. I want to also thank our audience for the participation and for the questions. The webinar has been recorded and is going to be made available later on. You can find it both in the National Academies Committee on Human Rights and also in the APHA later on. I finally, also the slides will be made available. I want to thank APHA, the National Academy of Science, Engineering, and Medicine, the Committee on Human Rights, and the National Academy of Medicine for co-sponsoring this webinar. If you have ideas or suggestions for webinar topics, please email apha@apha.org. And thank you, everybody. Thanks to Susan and to organizers and to the many people in the background that have made this webinar possible. And with that, wish you good afternoon, good evening, and good night. Thank you very much.
Thank you.
Thanks very much.